Welcome to today's webinar resident series, Fundamentals of Removables, Analog and Digital Processes and Materials. This lecture is being presented by our very own Tremaine Watkins, CDT. And with that, it is my pleasure to introduce Adam Dreyfus, Director of University, Government, and Institutions. Take it away, Adam.
Good morning, Jessica. Thank you so much for the warm welcome, and good morning to all of you. As you know, most of you know, I am the Director of University Government Institutions for National Dentex, and we thank you for your partnership. I know you're not here to see me. I know you're here to see our esteemed speaker. So without further ado, Tremaine Watkins, please take it away with the fundamentals of removables.
Hi, everybody. Thanks for joining in this morning. I would echo Adam's sentiments that this wouldn't happen without Jessica, and we really appreciate all her hard work. Let me jump into it. I got a lot of content to cover today, so here we go. I have a couple slides here at the beginning that just talk about, we're going to be talking about partials and dentures, but specifically how many edentulous patients there are. I know, especially in residency, you guys see a lot of edentulous patients, but there are general practices that don't really treat patients. I feel like this is kind of the key statistic, that there's 174 fully edentulous patients for every general dentist in addition to the partially edentulous. So there's a huge need for this. And I kind of multiplied out what we had before. And if you look at single implant crowns and single crowns at general, to kind of put this in perspective, there's almost 4 times as many dentures being done right now, in addition to people who aren't happy with their dentures per year, and nearly a third of the crowns that we're doing. So there's a lot of treatment opportunities and a lot of people who need help. And I think that the more that we add removables to our toolbox, the more we can help those people. So we're going to begin by talking about occlusion and dentures. Of course, occlusion is very important for any kind of full arch case, but for dentures, it becomes even more important. Couple definitions real quick. We're going to define occlusion as the way the teeth come together in a static position, such as when we're swallowing. And we're going to use articulation to refer to the dynamic tooth relationship when the teeth are chewing. One of the things that's difficult about dentures is that edentulous and dentate patients chew differently. As you guys know, dentate patients tend to chew in a warped teardrop pattern where they so there's more of a vertical component to their chewing movement, whereas denture patients tend to chew almost horizontally. One of the things that you know, as you're working with dentures, is that patients' main frustration with them is stability. And a lot of times we're chasing that with adjustments and relines and stuff like that. But with the amount of force that's applied by the occlusion, if we don't have a good occlusal scheme, we're not going to be able to develop a stable denture because we can't use suction to offset the amount of force that comes in from the bite. So we'll talk about this more as we're going along. I feel like VDO is kind of a forgotten sometimes aspect of dentures. As you know, everybody has a correct vertical dimension of occlusion, and oftentimes denture patients, due to the lost hard and soft tissue, don't have the correct vertical dimension. So one of the things we're going to want to do is, either by using the vertical dimension of rest or a conmedier instrument, we want to find the VDO and then capture the often open bite that the patient has. You can see that in addition to having functional advantages, it also has aesthetic advantages for the patients. Denture tooth occlusion has been a controversial subject. When I was younger, we talked a lot about bilateral balanced occlusion. And what the idea of that was that in function, all the denture teeth are either occluding on the working side or on the balancing side. They're very difficult to set in the laboratory. And then studies have shown that when you get a perfectly balanced occlusion on an articulator, rarely does that equate to fully balanced function. So what will happen is, if the function gets uneven, then it generates tipping force on our dentures. Lingualized occlusion has gotten a lot more popular in recent years. That's the image on the right here, B. And the advantage of lingualized occlusion is that you deliberately don't set the teeth to have any working or well, they have working and balancing contact, but they're not coming up a cusp, so they're less likely to create tipping. You might think that the chewing efficiency is less, but again, the studies are showing that the chewing efficiency is similar with both of these, but patients are perceiving, even with a very well executed balanced occlusion, that when they get to try both, that they're finding lingualized occlusion is more stable for them. So the difference between the two is the cusp angle of the mandibular posterior teeth. You'll probably hear this quite a bit, that posterior teeth have numbers. They'll say they're 0, 10, 20, 33, whatever. And what that refers to is the angle of the cusp relative to a flat plane. Teeth with larger angles tend to look more aesthetic and can be appropriate for partials. But when we use high cusp angle denture posterior teeth, we can tend to create those tipping forces. So most of the time, you're going to get a good success if you do a 22-degree tooth on, or a little bit less on the upper, and then a 10-degree on the mandibular teeth, so that way you get this more stable lingualized occlusion. Again, most of the time your laboratory will be setting your teeth, but one of the things to keep in mind when you're working with dentures is that most of the things that affect a denture we can't see in the laboratory. We can't see the lips, we don't see the cheeks, we don't see the tongue. And so many times we're needing a proxy from you to show what those things are, and it's the bite block. So when you're trimming your bite block, be thinking about these things. Trim the incisal edge of the maxillary bite block to show how much tooth display, which is generally 1 to 2 millimeters. When you mark the high smile line, mark where you want the necks of the teeth, and then just say that on the prescription. Hey, I marked the necks of the teeth. So that way the lab knows how much tooth to show. And then we understand the aesthetics of a particular case. We want to mark the dental midline parallel to the facial midline. And most people aren't perfectly symmetric, so that's a bit of a challenge. So in a lot of ways, you want to get that bite block stable and then mark what looks good for that particular patient. And also look at lip support. I mean, most people are going to want their lips plumped out a little bit by their dentures, just making sure that they can still close. Anterior occlusion is a little bit different with dentures than with natural teeth. Whether it's a single arch or a double arch, we want to have a little bit of freeway space, and we want to set our overbite and our overjet at the same measurement. And you can see it's a little bit different here, but we usually want either 1 by 1 or 2 by 2, so that when the person bites in centric, there's no contact, but as soon as they start moving, we get even contact with the posterior teeth. A couple of things about the posterior teeth position. We have to set the posterior teeth over the ridge. This is critical. One of the things that I know I messed up when I was younger, and maybe some other people have run into, is that it's easy to think, oh, I got denture teeth, I can put them wherever I want, I can make them really pretty. The problem is that the posterior teeth are an extremely powerful lever. And if we set them off the ridge, then there's going to be so much tipping force on the denture that we're really not going to be able to create a stable prosthetic for the patient. So what does this mean? This means if a person is skeletally class 3, we have to set their dentures class 3. Because if we don't, let's say we take the maxillary teeth and push them out, then we're going to wind up with an unstable maxillary prosthesis that can't be fixed by adjustments or relines or whatever, because we're using the occlusion to tip the denture, basically. So we also want to watch out for tongue space. So when we set our linguals, we don't want them to be, we set our mandibular posteriors, we don't want them lingual to the mylohyoid ridge. And then we don't want to start coming up the mylohyoid ridge with that second molar. One thing to keep in mind when you're taking your impressions is that the retromolar pad is really important for a double arch case because we set the distal aspect of the plane of occlusion halfway up the retromolar pad. We want to, the upper, on the lower, it's a little bit easier to leave off a tooth. The person will still have good function with one molar. On the upper, it's a little bit more of a challenge. We don't want to put the teeth over the tuberosity, but if we eliminate that second molar, we're more likely to have cheek biting for the patient. So we want to make sure that, if at all possible, we size the teeth so that we can get 4 teeth on the maxilla. So when I'm talking about balanced occlusion here, I'm not talking about in articulation, I'm talking about in occlusion. We want to make sure that all the teeth are contacting, that we don't have uneven occlusion when dentures are delivered, because that's going to tend to lead to sore spots. And the flatter the ridge, the flatter the teeth. The American College of Prosthodontists has 4 classifications of denture patients based on how complex they are to do. And flat ridges make them the most complex, as do non-class 1 occlusions. So one of the things you'll want to think about as you're in practice is have kind of a standard for, okay, I will treat these patients, I'm going to get good success. I may need to lean on my specialty team for some of these more advanced cases. One of the things I wanted to show with this picture real quick is that, as you guys know, border anatomy and having a very large impression becomes important with removables. You need to make sure that you capture the depth of the vestibules, the full palate past the vibrating line, the hamular notches, retromolar pads, and especially the external oblique ridge, so that we can get a nice, stable denture. If you don't have those, we're not going to, we can have a denture that is stable as much as it is, but it's not going to distribute the occlusal force over as much of the tissue as we'd like, and that could lead to greater resorption over time, which of course we don't want. So let's talk about a typical analog workflow. We're going to go through an analog denture workflow briefly, then we'll go through the digital workflow kind of by comparison. So in the traditional workflow, it starts with a study model. And you might ask, why am I taking 2 impressions? And it's a good question. But one of the things you want to keep in mind with restorative work is that most procedures are going to take you a given amount of time for the whole thing, from the first appointment to the last. And you can either spend more time at the front end, kind of getting the case set up, planning, make sure everything goes smoothly, or you can spend more time at the back end, making adjustments, dealing with challenges. And as you know, capturing a mucostatic impression with the correct borders is critical to the success of your removables. So one of the advantages of doing a study cast for your first impression is that then you can do a custom tray, which will get good uniform thickness of impression material, and it'll allow you to border mold the case. If you border mold the case, make sure you let your laboratory know, because then we will duplicate the extensions of your impression on the prosthetic. We'll talk about how we do that when we get to the digital workflow. So your third appointment will be your bite block. We kind of talked about this, but the more you shape your bite block, the better your try-in appointments are going to go. So this edge here should be exactly where you want the incisal edges of the maxillary centrals. Obviously, the midline should be parallel to the facial midline. We talked about mark where you want the necks of the teeth. And then also the buccal corridor is very important. Look at the negative space in the patient's mouth and trim this so that it shows where the teeth should be. Last but not least, make sure you check the labial support for for the lip so that the patient has good lip support. And you can take pictures of your patient wearing the bite block. That can really help your laboratory as well. If you do relaxed lip, high smile, profile, then your lab can see, okay, you know, that person could use a little more support on their upper lip, or, you know, the buccal quarter is a little bit asymmetric right to left. And when they do the setup, they can make your setups even a little bit nicer. Obviously, your next appointment's your try-in. One of the challenges with a traditional workflow is that the base plates that are made for the bite block and the try-in fit similar to your final denture, but they don't fit exactly the same. And one of the things you have to decide, besides, of course, aesthetics, phonetics, function, all that stuff that you're checking, is fit. Is this about 90% of the fit I want? If so, you probably have a good impression and you're good to go. If it's a little sketchy, it's better to paint the intaglio surface of this with adhesive and take a reline impression before you go to process, because this is kind of your last opportunity to adjust the bite. So then we get to our fifth appointment, and it's delivering the denture. There's a couple things about analog dentures that could make them a little bit difficult just in general. The first thing is that we use a fair amount of force in the process of manufacturing these, turning the wax into plastic, basically. And it can lead to tooth movement, different things like that. So, you know, everybody does their best, but sometimes you're like, well, the setup was great. Why is the finish so different? That can happen. The other thing is that wax is a great separating medium. And so we go to great lengths to clean the wax off the necks of the teeth before we process the new acrylic in. But if there's any wax left, it can lead to delamination. So sometimes your denture is different than your try-in just because of the nature of the process, because we're going to talk about how digital is a little bit different. I put this in here just because, I mean, dentures can be great and everyone can be really happy, but it can be a real source of frustration. Firstly, the traditional process takes 5 appointments. So you got to figure out how to make money in 5 appointments. If you get any extra setups or whatever, those are non-compensated appointments, and that can be really frustrating. As you know, patients, you can have some problems with tooth delamination and breakage. And again, we'll talk about how there's some advantages with digital that help with that. Sore spots, instability, that sort of thing. Again, we want to manage that with border molded impressions and lingualized occlusion. The main thing I wanted to highlight on that is that if you are looking at a case and you think to yourself, this case is not going to have great stability, make sure that you've presented implants as an option to your patients, because regardless of what they do, it puts you in a better situation at the end. If you present them and they're like, oh, I don't like those, I can't pay for it, whatever, it's like, okay, we'll sign here. And then at the end, if they say, oh, it's not that stable, they say, oh, it's not that stable, just like you told me, as opposed to, how come this thing doesn't work? Well, you could have done implants. Well, how come you did? You know, we don't want to go down that road. So make sure that you're presenting implants to your patients that could benefit from it. You never know. They may decide they want to do that treatment. So lost dentures, as you know, those are kind of the worst with analog, because you're like, okay, my data is gone, so to speak. I get to start all over again, and I got to do all 5 appointments, which isn't that cool. So let's talk about what some of the advantages are of the digital workflow. With analog dentures, acrylic shrinks 8% during polymerization. There have been some advances in the chemistry, and we have injection molded dentures that help a little bit with that. But a perfectly made, brand new analog denture is going to have a slight misfit to the mouth. That's actually why we do post stamps, is because it kind of compensates for that, puts a little bit of pressure in that area. On the other hand, digital dentures aren't made the same way. They're built in 100-micron segments if they're printed, and they're milled to the same accuracy as a crown if they're milled. Most labs are printing, so we'll talk more about printing as the process. when the teeth are attached to the pink base, they're bonded in a similar way to how you do a direct composite restoration of the mouth. So there's no wax to get in there. They're bonded during the curing process. Essentially, they become one piece. They can't come apart. The first generation of printed materials were not awesome. And for people who have used those, they've kind of gotten a bad taste in their mouth, I think, about digital dentures. But the newer generation are even stronger than an injected denture. So injected dentures talk about 79 newtons of flexural strength, which is a lot. The Lucitone digital print resin, as an example, has a flexural strength of 200 newtons. So you're taking the strength to the next level. You can preserve the denture file. Most of the time, there will be two files for your denture, the base and the teeth, and you can ask for that from your laboratory and then save it in the patient's chart. So if it gets lost, or even if it gets broken and you're like, well, I don't want to fix it, you can send it to the laboratory and ask for a reprint and reassembly. And then continuity, I think, is really important. One of the cool things about doing cases digitally is that you're preserving the previous data and moving it forward to each step. So it allows us to get you what you see in the try-in with whatever adjustments you want, and get you a more predictable result. So how can you do digital dentures? You're like, well, I don't have an iOS, or I'm not very good at scanning dentures, or scanning dentures is hard, or whatever. How do I do it? Well, what's cool is that you get the most benefits from the digital denture process if you use your iOS scanner. But if you take a really nice border molded impression, you can have all the advantages of a digital denture while doing the first 3 appointments using the analog process. So if you want to do the analog process, you do your preliminary impression, and then your custom tray impression with border molding, and your bite block the same way that we talked about. So follow all the same processes, all that sort of thing. But here's where it gets different. So this is what your try-in will look like. Well, hopefully not this. This one needs a lot of adjustment. But you'll get a printed monoshade denture. So a few cool things about this. The first thing is that it fits exactly the same as the final denture. There's no block out. There's no other than digital that will be the same on the final. So you can 100% evaluate the fit. Another thing about this is it's obviously not as pretty as the final denture, but it's sturdy enough that you can send it home. So if you would like your patient to do what we sometimes call a test drive, you can make some quick occlusal adjustments if you need them, send the patient to wear it for a few days, and then bring them back and then do your adjustments. And if you need to do any in your assessment, take your photos, that sort of thing. The other thing that's cool, if you want to do a digital process, you can rescan after adjustments. If you want to send the prosthetic in, you can do this. You can mark, hey, I want to add more here, rotate this tooth, fix that length, shorten, move the midline. Obviously, you can grind on it or add to it. It's a type of composite. So if you want to do that, you certainly can as well. So you have a much more robust try-in prosthetic. And so then you get the printed final. And like we talked about, one of the things that's cool about the final restoration is that we can make any changes if you need any from the try-in, and then when we print it, the process is totally different. So there's not that high pressure process that can lead to fracturing or whatever. The teeth, these days, the teeth and the base are both printed, and they're printed in 100 micron segments, layers basically. So so you get, your deliveries are much more predictable. I was talking to a dentist who had switched his practice over to this, and he and his wife practice together. His wife does all the other restorative work, and he just does implants and dentures. So I love dentures. And it had been a source of frustration for him in his practice, because he'd be like, okay, I did the bite block. Well, the setup's not exactly what I expected. So, okay, work on the setup. Then get the setup where he wants it. It's like, oh, the final isn't exactly what I wanted. And he said that's been his favorite thing about the digital process, is how predictable it is. It's like, if it's good, you just carry the goodness all the way through to the end. If it needs some, what am I trying to say? If it needs some adjustments, the adjustments are predictable, and you know that you're not going to lose the other things that you like to change a few things. So if you want to do a fully digital workflow and your scanner can scan soft tissue, you can scan soft tissue, do a bite block, that sort of thing. But we find the best results with a reference denture, because one of the challenges with scanning is that you don't get the effect of border molding. So oftentimes the scans aren't really mucostatic because the wand is moving the tissues and not creating exactly what you want. With a reference denture workflow, you add any segments of border that are missing, and then you border mold with a heavy body material, and then you reline and do border molding one more time. So technically you're taking an analog impression. Make sure that you don't alter the patient's denture during this process so that there's not hard feelings between you, but you can put a little bit of impression adhesive inside here, and then you can just clean that out with IPA. So let's talk about how you do the border molding. So for the maxilla, you want the patient to open and close while you're holding the denture in the premolar area. And then you want them to move their mandible side to side, show a Duchenne smile, and then pucker. So if you have enough time with the setting of the material, you can have them go through those motions twice. And one little trick is that you can paint the adhesive. It takes a minute for it to set. You can have them practice doing the border molding movements while you're waiting for it to set. And then you're like, okay, I'm going to put the denture in now, do the same thing. For the mandible, the process is similar. You'll want them to pucker, show the Duchenne smile, then stick their tongue out and up and move it side to side before closing and swallowing. So you'll do that twice, once when your heavy body is setting on the border and once when the light body is setting. And that's the same technique you can use for your master impressions as well. So your denture, your reference denture should be very stable at this point. Should have suction on the upper. And for the lower, the way you can kind of test it is try to tip it towards the posterior. It should be very resistant to that. If they're moving around, you'll probably want to retake the impression. Now that they're stable, if the person's overclosed, you can use a leaf gauge to open them to the correct VDO. And a lot of times, it's easier to take a PBS bite that you'll capture with your iOS, just because, especially if you're taking an open bite, because it's difficult to create it predictably while you're scanning at the same time. So you have this. What do? So what you'll do is you'll go ahead and trim this, any excess material that's up over the cameo surface. Same thing with the bite. I would trim this area off here. And then you can actually do an extraoral scan on this. So for the maxilla, start on the cameo surface, scan back and forth, make sure, or not, sorry, the intaglio surface. This is really important. Start on the intaglio surface, scan back and forth, rolling over the borders. And then once you capture that, go over the borders and capture the whole cameo surface. You'll either have to use denture scanning on your settings or turn off AI trimming, depending on what system you're using. So same thing on the mandible, and then you can put them together with the bite, scan the bite. Clean all your impression material off, use a little bit of IPA to take off the adhesive, and send the patient home. So that's your first appointment. So far you have one appointment. So your second appointment, your laboratory, this is kind of how the design process works. The purple is the person's previous denture, and then the white are the new teeth that are being set. So you can see that in the laboratory, we can either follow it exactly or we can make unlimited changes. It's nice if you take photos of the patient wearing those relined dentures, because again, it just gives us more information about their face. And you have all the benefits that we talked about before. So the when this gets turned into a single shade try-in, it'll fit exactly like the final, et cetera, et cetera. So your next appointment will be a try-in, and then you go to a finish. So this is a very predictable 3-appointment denture, so you can get probably better results than a 5-appointment analog denture while you cut 2 appointments out. And usually the try-in and delivery on this are much less time consuming as well. It takes a minute to do most of the time on this is front loaded doing the reference denture scans, but even that you'll find goes faster as you get more experience with it. One thing I would say is that a lot of us, including me, when we started scanning dentures, we started scanning on the cameo surface, and the camera has a hard time going over the borders into the intaglio. So we found in general that it's easier to start on the intaglio and kind of take a broad scan where you're picking up some cameo surface all the way across. So anyhow, that's I would say the best way to do a digital denture today. So printing or milling. So when digital dentures got started, they were all milling. Laboratories would mill either a 2-shade or a 1-shade puck of PMMA and deliver that to you. PMMA has some advantages, especially early. It's obviously it's acrylic that's made in a commercial environment, so it doesn't have flaws, that sort of thing. There's no processing problems. But milling dentures is very slow in the laboratory. It takes several hours to mill 1 arch, and there's no economy of scale. If you do 100 arches, it takes the same amount of time to mill 1 arch. And sometimes, as you know, there's big undercuts in the maxillary anterior, and even with 5-axis milling, there's a limit to how deep a undercut you can mill. And last but not least, PMMA, surprisingly, because we work with zirconia in a green stage, PMMA is harder on the equipment than zirconia is. So I would say today, printing has the advantage. From a theoretic perspective, of course, it's always going to have an advantage because you're not wasting material. You're not throwing away the puck. You only polymerize the material that you need. But we've had some really good advances, like we talked about, so that now we can make really strong dentures. Now, talk to your laboratory. It's just like you. You have materials that work better in your hands that maybe your colleagues might use something different. And it's not different with us laboratories. So talk with your laboratory about what they get the best results with. Immediate dentures. This is a workflow that really works great for digital because all you got to do is scan the upper, scan the lower, scan the bite. The main thing is you have to remember to capture those vestibular borders, all that anatomy. So you got to be thinking denture scan when you're scanning it, not crown scan. The other thing to keep in mind about these is that normally we do what I call lab extraction, which is we just basically digitally cut the teeth off at the gum line. If you do want some alveoplasty, let your lab know. In general, my experience is it's better to let us do what we do and then plan on putting some linol in there after the extractions. And then what's cool is that you can use your immediate denture once the patient's healed to do the reference denture workflow. So you can scan it. And if the tooth position is good, you don't have to do a try-in. You can just do a scan and a finish. So it'll let you do your final in 2 appointments. So that can be kind of cool. Let's talk a little bit about partial dentures. Kennedy classifications. These were developed so that out of all somebody looked at it and there's 65,000 possible combinations of teeth in edentulous spaces. So the idea of the Kennedy classifications is to organize tooth situations so you can kind of know, okay, these kind of cases are going to have this sort of challenge. Like Kennedy class 1 is going to tend to move in the posterior. And so we have to deal with that in our design. Kennedy class 2 is going to have an axis of rotation. So we'll need to manage that. Kennedy class 3 should be pretty stable. And sometimes we can do unilaterals. And then Kennedy class 4, of course, most of the time you have the the challenges with these cases are going to be more aesthetic. And again, with partials, under promise and over deliver. We'll talk about some of the cool materials. So whether you're designing the frame yourself or looking at the design from your laboratory, we kind of want to go through these characteristics of a partial in this order. Of course, we need good retention, and it's got to be enough to where the partial is not going to be easily dislodged, but we don't want it to be so difficult that the patient has a hard time taking it in and out. We also don't want to get accelerated abrasion of the abutment teeth. Stability. Now, this is an interesting topic because with a Kennedy class 3 or 4, we can often get a very stable partial. With a Kennedy class 2, we're going to get a little bit of movement, but we can prevent lifting. The main thing we can't prevent is movement, tissue compression on biting. With class 1, there's going to be some movement. So we'll talk about this, but this is where you use your eye bars because you want to have the retention be effective even when those saddles are being compressed a little bit. And we want broad areas of tissue contact, especially on 1 and 2, so that we don't accelerate hard and soft tissue loss. We want to make sure that our partials support the patient appropriately and that they're well supported themselves. We'll talk about that simplicity is really important in partial design, but we also want to distribute the load amongst enough teeth and amongst enough stable teeth so that we're not destroying more teeth with our partial design. Comfort's interesting because if we get these first 3 right, we're probably gotten a long way towards what we need. Other than that, it's mostly going to be technique. Is it smooth? Have we avoided gaps? That sort of thing. And I'd say aesthetics are the biggest challenge with partials. We want to make sure that the clasps are hidden, which is going to depend on the patient. But if we think that the person's going to be able to see the partial, we want to paint a worst case scenario at the beginning, so that way the patient is pleasantly surprised by the results that we get. So when you're looking at a partial design, less is more. If we can make a component of the partial do double duty, so much the better. So if one of the minor connectors also serves as a guide plane, for instance, that's great. The reason is this will be more hygienic. We want really good base adaptation because a couple of our classes allow movement, and so the base adaptation is our best way of presenting that movement. If we don't have to prep rests and that sort of thing, that's better. So that's what's used, what's present. Plan for the future. If I think the person's going to lose a lot of teeth, I want to maybe use a metal partial with a plate in the interior region so that I can attach teeth to it. I want to make sure the person doesn't bite on the rest. And then again, as most of the time on the partial teeth, we want to get group function. This is kind of talking about the different kinds of fulcrum lines. So what this means is that we're going to have rests along the line, and then we're going to want to have a clasp assembly or at least a rest like here, for instance, or here to prevent rotation along that axis. So when you're looking at your partials, you want to think about that. Guide planes. Guide planes are areas of the partial that directly contact the tooth, and they kind of work like a precision attachment. They provide a lot of stability and retention without adding clasps. So you'll want to have more guide planes on your case, especially if you have like a rest here and here, you may as well create a guide plane because then your guide planes are stabilizing the partial and your clasps are just providing some retention. These are important rules with this. And then when you're doing your rest design, you want to make sure that you have good occlusal clearance. You want to make sure that they're 1/3 to 1/2 of the mesial distal width and 1 to 1.5 millimeters deep. We want to avoid putting rests on incisors if we can. Better to put them on the cingulum of the cuspids. We don't want to put rests on amalgams. And Also, make sure that you round your internal line angles on your rest preps, because the partial will be the mirror or the negative of it. And of course, sharp corners are where things break. So a nice round corner is helpful. A good direct retainer, a clasp has all these things. And this is one of the main thing I see with clasps, is that sometimes they don't encircle the tooth enough. If this clasp ends here, all it's trying to do is push the partial in this direction. So it's really important that the clasp go past the height of contour of the tooth to get really good circlement. Passivity, meaning that when the clasp is down, we don't want it to put torque on the tooth. Tissue support or tooth support, really important decision. As you guys know, externally loaded bone tends to resorb, while internally loaded bone by a tooth or implant is retained. So if we're choosing to do a partial for whatever reason that is mucostatic, we do want to talk to the patient about the risk of increased resorption, and also the importance of doing regular relines and or new prosthetics to make sure that we have good adaptation, so we're not accelerating that process. So what are some options for partials? Chrome cobalt metal frame partial. Now, I get that this has been around since the 20s, the 1920s, and you're like, well, okay, why are we even talking about this? There's a lot of good stuff about it. There's been some concern in the US on the chrome cobalt, but there were some studies in the a meta study in 2022. They studied 21 in vitro and in vivo studies over a long period of time, 95 to that time. And it showed that while chrome cobalt isn't quite as biocompatible as titanium, it's much more than nickel, and there was no cytotoxicity to human cells during in vitro. The reason that we still use this is because it's such a nice solution. It can be thin and light. It's very, very strong. The same material that makes up the base can make up the clasp, and it can be repaired. You can repair the acrylic, you can replace or repair the teeth, and you can repair the metal. So it's really a good solution, and there are some cool digital workflows that are coming out for this. The main thing is it's not super aesthetic. So there are some things that we can do to kind of help with that, but don't leave this out of your treatment planning, because there are going to be some patients where this will be the best solution for them. All acrylic partials are sometimes called temporary partial flipper. They are the most economic. They usually don't have awesome adaptation compared to some of the other partials, so they're going to have a little bit more movement, and they don't have a frame in them, so they sometimes aren't quite as strong. These are probably best for a temporary solution while you're waiting for a patient to heal. Flexible partials, they're not new anymore, but they are a great solution, and patients love them. In the laboratory, we probably get the most positive feedback about this kind of partial. Valplast is made out of nylon, Duraflex out of polypropylene. They're both very durable. The main thing you need to keep in mind is that Valplast cannot be repaired because nothing sticks to nylon. And Duraflex can be repaired, but it's not as reliable. So you want to make a flexible partial for a person whose oral environment is stable. In other words, if you're planning on losing more teeth or something like that, you may want to use a different kind of partial, either a frame partial and add to it, or acrylic partial as a temporary. But you want to get your patient nice and stable before you do this. The other thing to keep in mind is that the whole Valplast is flexible, or Duraflex. So when the patient bites on this compared to the metal frame partial, this is going to have some give. So it's okay. Just make sure you have a discussion with them about that. Again, talk to your laboratory about what they've had the most success with. Combination partials. A lot of people don't even think about these, but these are kind of a best of both worlds thing. So what you do is you make a frame to give you the strength and retention and lightness and all that stuff. And then when you process it with a flexible resin. The main drawback to these is you can't try in the clasp until the end, because the clasp is part of the processing. But these can be a good solution. They're sometimes overlooked. Clear frame. There are a lot of resin frame materials out there. We haven't seen a lot of success with other ones but this one we have. So this, you can do rests on it, which is cool. Like with Valplast and Duraflex, you can't do rests. So in other words, it can be tooth-borne, and you can design it like a metal frame partial. All the components need to be thicker, but it truly is clear. The main thing is this is a nylon material as well, so it cannot be repaired. So this is traditional teeth, traditional acrylic, so you can reline it, you can replace teeth, but you can't repair the frame. Partials are also a great workflow for digital. Most of the time, you're going to do a 2 to 3 appointment process. You'll do your iOS scan. Again, you'll do it like you were going to do an immediate denture. Just make sure that you capture the borders and the palate passive vibrating line, annular notches, all the stuff we've talked about. Keep in mind that one of the cool things about iOS is that, as you know, a partial is like a really big crown and bridge type bridge. So any distortion is going to make it so difficult to see. And one of the cool things about an iOS is if the scanner captures it, it's at a high enough degree of accuracy to make a partial. In other words, the scanner, if it's having trouble, it just won't build the file. Click, 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 nothing. So if you see a good scan, it is a good scan. So that's cool. If you want to do a try-in, of course you can, and I would recommend it for cases where there's aesthetic concerns. But otherwise, you may be able to go straight to delivery with most of your partials. Again, bites are also much more predictable with an iOS scanner, even if there's only a few teeth in contact, because we don't have to hand set the case. We can actually just bring in the bite that you've taken. So one of the other things I would say about us laboratories is that some labs are more digital than others. Some labs are like, how can I do it digital all day, every day? Some labs are like, how can I take this digital data and put it back into my analog workflow? So kind of when you're doing your first digital case with your laboratory, kind of talk about the workflow. And if you're seeing too many appointments, push back a little bit. It's like, well, I need to do, my patients would prefer that I do the least amount of appointments possible. How can we do this case in the least appointments? I feel like is a fair question to ask. Well, that's it. That's all I have this morning. Thank you very much for joining in. I really appreciate your time this morning.